what's new in urgent care in this
Well,
time of year?
before we jump in, I want to just say one little item. One of our viewers recommended to me the title, maybe a potential title for our little whatever we call these sessions.
Yeah,
So
sessions are good.
I was told we should think about calling it Triage After Dark, where the vitals may be stable, but the stories are not.
Never stable, never
What
clear.
do you think? Does that grab you or
That,
what?
that
Triage After Dark?
that's not bad.
I don't know.
I think
Consider it.
I guess the
Catchy.
title of this one would be,
I
we're
forgot.
finally heading into nicer weather.
This is
So,
true. Finally, we made it to late April. Good point. So, what happens in when the weather changes, things change.
well, we spent plenty of time talking about ticks, which are everywhere.
I've had two
Um,
cases this week of legitimate anaplasmosis.
oh, we've had quite a few tick bites. I don't know that we've had any. We've had a couple
Yep.
of Lyme.
Yep.
I'm trying to think. I don't know. We haven't seen any anaplasma, but you never know if it's co-infected with Lyme because if we treat for Lyme.
Right.
Babesia, we haven't seen any of that. But let's put that to the side. But we could talk about other insect bites that are going to be coming out soon because exactly. But no, you get infected spider bites, horsefly bites, bee stings, mosquitoes,
I was up
black
on
flies.
Lake George on Monday, and the black flies
I've
were
heard.
out.
Yeah.
Black flies were out.
So what can people do for number one, prevention, number two, for kind of treatment of black flies, mosquitoes, all the other nasty stuff?
Yeah, some people are a little bit more sweeter. The bugs like them more than other
Yeah, I had a
people.
conversation with somebody this week about the blood type. Somebody's convinced it's the blood type.
I'm not sure it's that so much, but I don't know what it is. But yeah, I don't know. And the prevention, I mean, don't go out. There's not a lot of options in terms of that. We live in their environment more than they live in ours.
Yeah, but so if it's a concern, if you're hiking in the Adirondacks in June, right?
Yeah,
You may
I put on stuff.
Tuck your pants into your socks, spray your socks and your pants and your boots with permethrin, long sleeves, wear a hat, maybe wear one of those, handkerchiefs, like a cape over your neck type of thing with permethrin on it.
Okay.
Those are all
like a bandana or
yeah,
something
yeah,
like
yeah,
that?
yeah. So those are all things you could do for
I'm
prevention.
envisioning you like from your high school days, tucking your pants into your socks. Is that ringing?
Interesting.
Mint.
Well, that's the natural Dara approach.
You're rubbing mint on or eating mint?
Or put like a mint leaf in your hat type of thing.
Seems like a kind of a waste of a good mojito, but that's just me. I don't
know. The other thing is, of course, insect bites. If you get into insects, right, you get hit with a bunch of mosquitoes or something. Long-acting antihistamines. People call me, can I take a dose of Benadryl? Most people can take a dose of Benadryl. Number one, it causes sedation. Number two, can cause urinary retention. Number three, it's short. Its half-life is about maybe 6 hours. Yeah, so I always say use your long-acting non-sedating antihistamines, your loratadine, cetirizine, fexofenadine. Those are my sort of go-tos. What is cellulitis?
Sensitive skin. In that case, usually those are like our hives. Those are hypersensitivity reactions, not really true cellulitis. True cellulitis, superficial infection of the skin or soft tissue caused by bacteria that lives on the skin. And it's supposed to be there. Doesn't matter how much you bathe, it's going to be there. But if you break the surface integrity of the skin, bacteria can get in the skin and set up a secondary, hopefully low-grade infection. Now, how do you break the surface integrity of the skin? You get
an insect bite.
You get a bite, or you scratch, or both.
A pricker.
Well,
a thorn.
Those types of things. Yeah. Lots of ways to do that. Yeah.
So again, I think the insect bites, rashes, summertime, long-acting, non-sedating antihistamines. If you have a localized rash, whether it's like an erythema migrans, which is your Lyme rash, or if you start to get like a localized redness, feels hot, warm to the touch, tender, you start to feel sick or ill, that's where I would definitely say, stop treating with the over-the-counter stuff and, get to an urgent care.
Come get seen.
Yeah, come get seen here.
See your primary care doctor. But
exactly.
But I mean, in terms of other things you can do for these sort of hypersensitivity, these bad bite reactions, where you're like really driving you crazy, in the short run, a little topical hydrocortisone cream.
Hydrocortisone cream is great after bite.
Topical witch hazel, topical Benadryl combination.
I think topical Benadryl is like sort of my favorite.
I like baking soda plasters for that.
Calamine.
Calamine is calamine, Caladril, all that kind of stuff. Yeah. Sarna lotion is pretty good as a moisturizer. That's over the counter.
Yeah.
But I mean, I think there's a lot of applications out there potentially to try. I think a lot of folks will come in. Now, you correct me if I'm wrong, but a lot of folks will come in whose first line in their mind is oral systemic steroids.
Yeah, I mean that's kind of like fighting a fist fight with a hand grenade, right?
Well, right, but that's an approach, and people come in and will be like with very localized eruptions, reactions, whatever it might be, and like, can I get? I'm like, yeah, you probably don't really need to expose it to that treatment yet, at least.
Yeah.
Let's see what we can do, maybe more conservatively in the short run, and oftentimes I find that the biggest stimulant for the patient's reactions and symptoms is they just don't leave it alone. You get
it's hard to though.
It's hard to. You get scratched at, you scratch more, and you scratch more. So my approach is if something like that happens, I'm going to hit it pretty fast with the witch hazel, Caladril, hydrocortisone topical, just to kind of and even cover it so it's sort of out of sight, out of mind. Less prone to chafing, which makes it itch more.
Yeah, and also I'm a big fan. Even we talk about over the counter hydrocortisone cream, Caladril, those kind of things, but also from a prescription standpoint, the high potency steroid creams are very effective and can a lot of times kind of nip that right in the butt.
Sure, you got to get a prescription for that. And you got to be careful utilizing it.
Of course, you can't put it on your face.
I prefer if you don't do that. Areas. Yeah, I mean, or use it very sparingly and for the briefest amount of time you can. And there's a wide, as there's a wide variety of topical steroid preparations out there from super low potency to super high potency. And the more potent it gets, the more it can potentially provoke adverse reactions.
Problems.
Yeah, problems, exactly.
All right, let's get away from insect bites and chat a little bit about other stuff that causes rashes, like plants. Because some of us walk by a plant, break out with a rash.
You got that right.
Pine trees, poison sumac, poison oak, poison ivy, grass, all the different allergens.
Yeah, what do they have up there? There's a lot of that poison parsnip stuff up there in the farms.
Yeah.
You see that a lot. That's pretty tough.
So a lot of times people come in and say, oh, I don't know what I got into. I have this rash. I've never been allergic, or I haven't been around any poison ivy. I mean, contact dermatitis you could get from a whole slew of things. It doesn't have to be poison ivy per se.
Right. Or it could be your pet was outside, went through it and came in and got onto you.
Yeah.
That happens.
So again, the treatment for, contact dermatitis, which is when you become in contact with something you're allergic to and you have a topical local reaction, is pretty similar to that of insect bites. It's your antihistamines, topical
don't
antihistamines,
scratch if
topical hydrocortisone, witch hazel. So the rashes, again, you come in contact with something. One way to, and again, we differentiate is, contact dermatitis versus I don't know what I have. If you come in with a rash and it's sort of all over your torso, probably not likely a contact dermatitis, unless, of course, you were outside without a shirt on doing yard work. You come in and you have a rash on, it's warm out, you have a rash from like your elbow to your hands and your knees to your ankle, that's a pretty good indicator that it's contact dermatitis versus a lot of the summertime rashes, pityriasis rosacea, right? And Coxsackie virus, right?
Well,
that's spring rash in kids. Heat rash. So again, the contact dermatitis is usually exposed areas, and then your viral rashes are more so where on your torso, belly, back. Of course, Coxsackie virus, which is common in pediatrics more so than adults, hand, foot, mouth disease. That being said, can adults get Coxsackie virus?
It can.
Yep, sure can.
I'm sure you have.
I actually, knock on wood, didn't when all three of my kids had. So that's kind of some of the rash stuff. What was it? What do you know about? Well, not what do you know, but what do you think about? What are some pointers for sunburn protection? Treatment?
Yeah, I mean,
when do you see treatment?
Right. I mean, when do you see treatment? I mean, people come in for pretty bad sunburns, but the reality is most of the time that's going to be a function of moisturizers, pain relief, avoidance.
So I get
time will tell kind of thing.
I got sunburn on my neck and my shoulders.
Right.
What can I do? Shy of coming to urgent care and paying a copay.
Well, don't pay a copay, pay the whole pay. But sorry, but I mean, again, I would say if it's bad, you got to moisturize the heck out of it. You got to purchase a high quality moisturizer.
What about
to really?
What's the one aloe? Yeah, what's the aloe? What's your take on aloe?
Aloe's good. I mean, I like lots. I like Aquaphor. I don't use a brand name necessarily if I'm really serious about it.
Plant aloe and the ones that have the methanol in them.
Methanol?
Methanol.
Menthol?
Menthol.
Methanol is
we'll edit that out. Yes, that's what I thought. So methanol.
Menthol.
Menthol, great. Okay, so
Isn't that irritating though? I would think that would be kind of burning.
It's a cooling sensation.
Really?
There's also I think they're over the counter now. It's just like a aloe with lidocaine in it. So that 1% lidocaine.
Okay,
So
give it a shot.
I mean, what's the most important thing you could do for sunburn of 1st degree, 2nd degree? God forbid, I can't imagine anybody gets a 3rd degree.
sunburn.
No, but I mean, you can get a 2nd degree sunburn.
Well, you get blistering.
Yeah,
sun poisoning.
But
I've seen that.
No, but hydration, right? We can talk about all these medicines, but the best thing you could do for a sunburn is hydrate. For again superficial 1st degree sunburn, even 2nd degree, and NSAIDs, anti-inflammatories. But again, you got to check. Make sure you don't have any comorbidities, underlying disease.
If it's hurting you, you treat your pain, hydrate up, moisturize up, prevent re-burning from occurring prior to you being healed.
Any input on the sunscreens? I know some people say anything over 30 is a hoax. Some people say don't bother with anything less than 50.
You talk to my wife. She is all about 50 for the body and 75 for the face.
Really?
Oh yeah. High power.
Does she use
lots of the products around too.
Does she use any sprays or does she use the creams?
No, both, but
really?
mostly the creams.
So I have found anecdotally, a lot of the sprays are alcohol based. So I do find that people spray themselves with alcohol, and they can cause like a contact dermatitis from that.
Really?
Yeah, especially out in the sun.
Yeah.
So.
I don't disagree with. Well, and then you get, what do they call that? Solar dermatitis.
Yeah, maybe it's more of a solar dermatitis than a contact dermatitis, but either way. Speaking of which, another great sun thing, right? What some medications that can really wreak havoc out in the sun?
Oh, well, a lot of them. Of course, our favorite. We just started the day off having a conversation about ticks and related illnesses. Doxycycline and sun exposure is
tetracycline.
The tetracyclines are fairly well documented in terms of the response to that. Now, during the sunny half of the year, which is like now through October 15 in my mind, I do caution people if they're going to be on doxycycline or tetracyclines for more than a week to practice avoidance or sunblock or cover up or whatever it is, and give them warning about the possibility. If I cannot use it, I will not use it.
Yeah, but I mean, then again, you're weighing risk benefit.
The medications come to mind.
Sulfa.
Yeah, what's that about?
Similar sun reaction, yeah. And in the sulfur class is your thiazide and hydrochlorothiazide diuretics. So not as common, but definitely on the radar there. So things to think about. Also, again, speaking of diuretics, if you're on diuretics, you're going to be out in the sun. Make sure
you're going to be dried out.
Make sure you hydrate aggressively, right? Try to keep that in mind. I had a conversation with somebody this morning about tamsulosin for BPH symptoms. Back in the ER, very common thing to see is a couple of guys out on the golf course having a few beers, and then boom, Jonathan's down on the ground. Why is that? Well, so tamsulosin, which is used to treat BPH, which causes, predisposes you to symptomatic orthostatic hypotension, to go out in the sun, get vasodilated, have a few beers, and now you have, more problems. So.
When's the most dangerous time being out for sunburn?
Oh, peak tanning hours.
When's that?
When it's like really sunny or hazy or.
Oh, you mean when? I see what you're saying. Good question. Yeah, so we get faked out when it's not so sunny out because all that UVB penetrates cloud cover anyway and still burns you up and you don't realize it. So good point. I
think. Anything else for the summer session?
Sunburns. When should you be concerned about skin cancer from it?
Always.
Well, that's why we're sunblocking, exactly, because we want to prevent that occurrence, because that is a very real, UV radiation causes a lot of problems.
So what is it? If you have any serious sunburn before the age of 10 or something, markedly increases your risk for. I forget what the data is, but it is legitimate. It is there. The reality is, most of us who've been burnt pretty good, any mole needs to be looked at, and they should all be taken seriously.
Right.
Squamous cell, basal squamous, melanoma.
Yeah. That's why people spend a lot of time and effort and money buying things like sunblock products. I can vividly remember, though, way back in the day, long before you guys were born, people would slather up with
oil,
coconut oil, and
baby oil. It wasn't before I was born.
To tan, and it was holding the reflectors on their faces on the poolside to get that burn, get that tan.
What do you think we did in Boca Raton and Fort Lauderdale when I was, growing up on spring
You're
break.
still doing that by now?
Oh yeah, yeah. Well, I wasn't, but my
People
mother
still
was.
do.
Yeah, you're out. Well,
Yeah,
your parents are. That's what I'm talking about.
yeah.
They still
yeah.
do. Yeah, yeah.
And
But
so,
they're not using any sunblock at all. They're trying to enhance that, which is just you better be careful.
but the short of the story is that the sunblock and the skin cancer prevention. Yeah, you're trying to prevent a bad burn, but the reality is, you're trying to prevent a skin cancer down the road.
Correct.
Because that's where most of them come from.
I agree with you. Yeah, 1,000%. And it's, again, an ounce of prevention. It's worth going cure because what you don't want to have to do in your life is a malignant melanoma or a basal cell.
Squamous cell. I mean, yeah.
Basal cell, we deal with them. We don't want to deal with them. We do deal with them.
Yeah, I have a guy who had squamous cell metastasized to the lymph chain.
Cell.
No, squamous cell on the ear.
Yeah, squamous will do it.
Yeah.
Basal is considered to be a fairly benign cancer, but the reality is there's still a tiny percentage of basal cell that will metastasize if allowed to.
Yeah.
So you just mentioned a whole bunch.
So melanoma comes from melanocytes, right? The things that pigment our skin, right? The cells that pigment our skin.
Which those go, from one site, which are very hard to identify, to they metastasize
very avidly,
aggressively, quickly, and without
the central nervous system.
Yeah.
So really tough. Squamous cell. So squamous cell basically means a flat-shaped cell, and the squamous cells are all over your body. They're normal. They're really the underlying layer of your skin. Or
it's just when you get enough damage to them, particularly with UV radiation.
Oh yeah. And you'll see that a lot in folks who have a long history of sun exposure.
Work, and it doesn't have to be just
it's
sun tanning.
No. It's somebody who's just kind of
working as a lineman, working as a police officer.
Their head, their neck, their forearms are exposed. They may be wearing long pants and a shirt the rest of it, but there's still exposure. They're out in the world, chronically exposed, and they don't take the time because it's a regular work day. They're not going to slather up on sunblock, and they'll develop, maybe a squamous
or they
cell.
might when they're in their 40s, but when they were 16 through 30, they paid no attention.
Correct.
And then your basal
cell, typically superficial of the skin structure, and also stimulated by the same process. Do you guys do any basal cell work here, like freeze stuff off? Or?
We freeze stuff. We do a lot of we freeze a lot of actinic keratosis, which is a real precancerous lesion. We do some skin biopsies, like we'll do punch biopsies and such.
Which you'll send for path.
We'll send for pathology. A lot of times, if it's somebody who's like, I'm here, take this thing off right now, or I want this biopsy, we'll do it. The reality is, otherwise, I try to push people to go to dermatology just because, quite honestly, as we've talked about, if you have more than, I think the rule is if you have more than 11 moles, your risk for cancer goes up exponentially. So anybody who has quite a few moles, I do really encourage an annual dermatological skin cancer screen. Yeah. I don't see the harm in that. But again, if I have somebody here who's like, I don't know what that is, or it's a non-healing lesion, I'll biopsy that. But again, the short answer is, if it's malignant, they're going to dermatology or plastic surgery. That being said,
is there a Mohs surgeon down here?
Rensselaer County has. Actually, there is one in Columbia County, but he does the Mohs up in Rensselaer County. But again, if it was somebody who I biopsied and it was a malignancy, it might skip over the dermatologist and just go right to the plastic surgeon for definitive treatment.
Mm-hmm. Absolutely, yeah. So it's you don't want to just shrug off skin lesions. You want to really have someone take a look at it. There's probably a strong tendency. It's a skin lesion. It's all about based on visual pattern identification, looking on the internet and looking at pictures. But that's not always the best way to approach things, at least not at first.
No, skin lesions, I mean, they can look, I've had it my whole life, and all of a sudden it's twice the size, or it's changed color. For example, this is a woman who she had been to dermatology. They put her on a bunch of different creams, and nothing was getting better. And I was like, let's just
cut to the chase.
Yeah.
What is this? So, right. If we don't know, we need to find out. The way we find out is by getting a sample and sending it someplace to look under the microscope or a culture or something like that. So, the answer is not necessarily take more drugs or more treatments. Let's find out definitively what it is that is going on and how you would treat that subsequently.
And I've never really had patients complain because we wanted to get a definitive answer. Usually they're like, "Oh, thank you very much."
That's what they're coming for.
Yeah.
I think that just underscores such a trap that we all fall into in modern healthcare because we're all in such a rush to move along. And I'm the urgent care guy. I'm definitely in a rush to move along. Yeah. I'm the short attention span medical provider here, but I mean, the reality is sometimes you got to stop and think, and you got to say, well, what could be going on here? The answer isn't just take more of the same stuff or take some different stuff to try to sort of smooth over the symptom. The answer is, what do we got going on? Once we know what's going on, then we can figure out a treatment that actually makes sense.
Well, and that's also, sort of, again, getting into the primary care void, right? How many people do you see in urgent care because they've gone to 3 or 4 different people and nothing has, gotten followed through. They haven't seen the same person twice, so now they're coming to you as the fourth
who's
person.
a fourth person who's not really lending a lot to that. It's, if anything, it's just more, kind of roundabout, trying to figure something out. But we've seen a number of people who lately, maybe a little bit older, that kind of thing, who probably who should be seen by their PCPs for the complaints that they're presenting with. These are people with a lengthy history of chronic problems on multiple medications, coming in with symptoms that have been going on for weeks or months, that haven't been addressed.
Well, we had a new patient a couple of weeks ago come in here on a Friday. This isn't funny. It's sort of funny, but he went to his previous PCP office. He walked in because he couldn't get anybody on the phone. He's been having this horrible neck pain with numbness, tingling, and weakness down his arm.
Here we go.
It's now April 28th. Today is.
And he's
so
paralyzed.
this was in early April. He came in on a Friday after he had left his current PCP's office, and he went in there for neck pain. So they made an appointment for June.
Okay.
So
So at that point he's.
Well, somebody had told him about us and that we would, get things moved along. His MRI was done within 4 days, I think.
Thank you. Very good. Hopefully you found.
Actually, Dara got the
good job, Dara.
The prior auth, of course, because the insurance, we still needed the prior auth. But no, he has a huge anterior osteophyte on his cervical spine, and he's going to need surgery. I mean, waiting 2 more months, 3 more months wasn't going to get that any better.
Well, if anything,
what's what? Osteophyte? Oh, it's like a calcium deposit or growth off of a bone. Yeah, usually in a bone that's been injured, the body kind of sends calcium to,
or just
restore
like living life because you put a lot of reps on that bone and that joint kind of thing, and it just kind of reacts like an arthritis almost. Arthritic process. So I mean, the danger of it with that person, of course, is if that progresses to where they have motor loss. It
had encroachment on the spinal canal.
Yeah, obviously, because you have symptoms like that. You're pushing on some nerves. And that once that happens, you want to get those. You don't want those nerves compromised further because maybe they don't come back.
That's exactly right.
Right. So you don't want to wait months, to get that cared for. So good job, well done. See this guy, he's the man.
Yeah. So all right. Well, I think we could wrap up this session of what is this? Triage after dark. Or
I gotta say it again.
Triage in the dark. I'm not turning the lights off.
Okay. Triage after dark.
Was this from Josie? Yeah. This is from the daughter-in-law. That's
correct.
Why. Okay.
Triage, who's a fan? She's probably watching now. Triage after dark, where the vitals are stable and the stories are not.
There we go. Beautiful. Great. All right. So we'll see you for the next.
It's not dark right now. So.
Triage in the morning.
It's in the afternoon right now.
Yeah.
So. Anyway.
All right. Be good.
Thanks
for watching. Enjoy the summer.